to understand a little bit more about those folks that I don't know. How many are clinicians? Okay, many of you. And then any technology folks, either health information technology or computer science folks? Oh, that's right. Well, we work together. And what have I missed? Design? Bioengineering. Okay, great. So this is a great representation of what Donna was talking about in the first session related to teams and how to think about your audience. So, and what Susan reminded me this morning, so I have to be careful about my definitions and thinking about being clear about what I mean when I'm talking about some terms that may otherwise be representations of things that are not shared. The other thing before I dive in, I wanted to just comment on this room. I don't know if you all know, for our accreditation for the School of Medicine, you have to have a certain number of rooms that have enough seats for your core classes. But this room, unless you have a conference or something, usually is not filled with medical students because they sit in their homes and watch the recorded lectures and they don't go to class. So this room is designed for kind of the traditional medical school lecture, but it's not really designed for the type of talk that I wanted to do today, which I hope to be very interactive. So I really would like to think about this as more of a dialogue, and we'll talk about some of the things that I think are important in the field, but I also would like to learn more about what you're thinking about and what your work is bringing up for you. So I also want to thank Donna because she teed up a lot of the things that I want to cover, and we'll come back to. Were any of you at the seminar series, the mHealth seminar series in March? So a lot of this is going to be familiar to you because we covered a lot of this there, but the reason that I want to have this be more interactive is because we can use this time to dive a little bit deeper and use some real experiences from folks. So I want to talk about what the evidence is, where we are in using mobile and digital solutions for health promotion and disease self-management and decision aids, for example, where we are in the field and what we need to be doing to advance the field. And then some trial priorities for design, implementation, and scale. So we heard a question in the last session about scale and implementation. I want to talk about that specifically. But also we focused a lot on design issues, and I would completely agree. We're not utilizing what we need to be utilizing to create well-designed and usable types of tools. Okay, so those definitions again. I'm just going to bring everyone to thinking about what public health folks, I'm a professor in public health, think about when we think about mHealth. So we talk about the use of mobile and or digital solutions to facilitate healthy behaviors in individuals and to support the delivery of care in clinical settings. So this doesn't have to be a phone. It can be a tablet. It doesn't have to be mobile. It can be using a widget in a clinical care setting, for example. So it's a very, very broad field if you use that definition. But we've seen interventions that have used the internet and continue to use the internet for health promotion, disease prevention, or disease self-management. Disease self-management. Social media. Things like Facebook or Twitter or WhatsApp, for example, text messaging, apps, certainly. Does anybody know how many apps are out there available for mobile and digital, mobile health now? Would you guess? Is it tens of thousands? Hundreds of thousands? We've got, I think, the current number, 250,000? 285. somewhere upwards of 250,000 mobile and digital mobile app solutions for health and health promotion. When, a year ago it was at 150,000 plus. So the growth is exceptionally fast. But the median number of times that these are opened after they've been downloaded, saying nothing about how many of them are actually downloaded. But can anybody guess what the median number of times is that they're opened? Donna had the right answer. I don't know if anybody can see. One. So people, once you download, and there's only a handful of those apps that are even downloaded. And then once they're downloaded, the number of times that they're opened on average is one, well, the median number. We're starting to see a lot of advances in artificial intelligence and virtual reality. Those are pretty exciting. Machine learning, Donna mentioned that in the earlier talk, and of course sensors, which is something that has a great deal of enthusiasm in emerging technologies. So thinking about what we've learned from mHealth research, we do have now a growing body of evidence about the impact of these. So, I'll say, is there anybody here, I want to just kind of poll you and see what are some of the things that you're interested in studying in your work, in your research? Just shout them out. Contraception, okay, so, but specifically, what is the question that you want to ask, Marco?
Well, it's not actually not a health question related to that, but use contraception to effectively space pregnancies and prevent adverse outcomes. Closely spaced pregnancies.
Okay, so how can you use technology to impact contraceptive behaviors so that they can in turn impact health outcomes, pregnancies, etc.? Okay. Other questions? Okay, preventive services from providers. Can you say a little bit more about that? Oh, SBIRT. Okay, screening, brief, intervention, referral, treatment. For substance use, correct? Yeah. Okay.
Stress, diet, physical activity, and sleep.
Stress, diet, physical activity, and sleep. So there's a diversity of opportunities that we have, of course. Where I think a lot of the field began, and we're starting to see this transition, a lot of the field began in doing a lot of feasibility and acceptability work. Will people use these tools? Will people, can we use them to impact contraceptive behavior, to impact referral behavior, etc.? So we've got a lot of information that people will do it. Part of the key, though, is you have to have that well-designed trial, but that's not where the field began. And now I would say we're essentially lousy with a lot of feasibility trials. People will do this, they will use it, and they tend to like it. So we're starting to know a lot more that we have that information. We also have information that we can use these tools to impact some of those theoretical constructs that Donna started talking about with self-determination theory, for example. We can use these tools to build people's skills, to change norms, to engender social support, for example. We also have evidence now that we can use these tools to impact smoking, for example, physical activity, fruit and vegetable consumption, condom use, sexual abstinence, medication adherence. There's a growing body of evidence, not just of single trials, but research syntheses and meta-analyses that look at this. And then also a growing body of evidence that we can impact health outcomes. So blood pressure, depressive symptoms, and weight, for example. So these all, you know, there's a number of different options there. I mean, here's just some examples, right? You can use this as a glucose monitor, for example. Text for Baby is a text message program that was developed first and evaluated second. Mood Gym is an example of one of the mental health apps out there. There's a number of smoking cessation trials that have showed efficacy. This is from some of our early work using Facebook for HIV prevention among young adults. So you have a lot of different options. This is actually one that I wanted to come back to when we talk about dissemination. This is one that we did in Uganda, looking at HIV prevention for secondary school students. So what is missing now? So we're starting to get good efficacy data, but a lot of this is starting to also help us understand. We can show in our trials that if you expose people to an intervention using a mobile tool, you can get a result. However, we don't know what's under the hood. What's the pathway? How did we get there? So was it because they used this element of your widget? Was it because they used this element? Was it because they engaged with your text message? Was it because they did they played the game? We don't really know the process, the pathway about how those outcomes are realized. So we're kind of, it's kind of like a black box. When they're exposed to the smoking cessation intervention, they tend to quit smoking more, but we don't know how and why and how much is necessary. So that's that second one. We don't know the right mix of exposure and engagement. So what do we have to understand in order to do better there? We haven't reached highly marginalized groups consistently. So we're starting to see more interventions that are designed for groups that face health disparities and have differential outcomes, but we're not seeing that consistently. And a lot of what is being developed is for populations that are perhaps the worried well, or maybe are not even considered who the audience is. And then we seldom replicate or scale our work. And here's another question. So what gets in our way? So industry and health field disconnects. So what might you interpret my meaning to be there? So why can't we, like, what's keeping us from answering some of these questions? I'm saying that one of them is this industry and health field disconnects. Yeah, so we have different motivations, right? We would like to change people's behavior and impact their health outcomes. The industry partner may very well be interested in a commercial outcome, right? In some sort of financial benefit. Now, it's not that there's something wrong with either of those. I mean, those both might be fine. But the problem is that if well, you tell me, what's the problem if the industry focus is on the financial outcome? Say that again. You can't. Okay, so you can't make money with an app because there's so many of them, or because nobody will pay for it? Okay, so they're not going to want, so if we want to create an app, they're not going to want to do it because you can't make money with it. Is that okay? Yeah. And we've been intending to meet for like 6 months now? Yeah. Oh, great.
I think the way in which they evaluate feasibility or the effectiveness of the app are different. Healthcare is about causing change, behavior, or health outcomes. Industry is really selling it. What's the uptake? It's more looking at market.
Yeah. Great point. So we care about a health outcome or behavioral outcome. They might care how many people download it, how many times is it accessed, those kinds of things. So they say, yeah, it's great. It's working because people are downloading it or they are opening it. And that's not enough for us. Other points about that?
So my experience with being involved in startups like this is that we get to a certain point where people with the startup are really all the best intentions of some of the research base. And then the virtual, the VC, the virtual capitalists,
Venture capitalists.
We talked about this last night, gets a patient and gives the research out, because it's gotten it to market.
Right.
So it's also, they're on very different time frames than we are.
Mm-hmm.
And especially if you're in public health, they don't necessarily want to target people that I want to target, because those are not the people that have lots of.
Right. Yeah, so there's a bunch of things that you mentioned in there. I mean, one is I put it on the academic side. We've got these, incredibly long processes to generate an idea, to write a proposal, to get funding, to that interim step, right of the proposal, get rejected, rewrite the proposal, resubmit the proposal, get funding eventually if you do the trial, which you've designed to be 4 to 6 years long, and then publish the results, which is an eon in the industry side, and they don't want to work on that timeline. And the question in the last session from our neurology colleague kind of illustrated that, well, it might take 2 years to generate a paper, and industry doesn't want to move that slowly. So, I would say this kind of falls in that funding priorities. We are complicit in continuing to kind of follow along in that. We are complicit or perhaps victimized by the system that requires us to kind of seek funding in this cumbersome manner. So we don't have really great funding structures that help us to support the teams that we need. So that's really missing, and that gets in our way, I think. Okay, so this is really, really hard to read, but how many of you are planning on or are thinking about clinical trials using some sort of text message or, let's see, or web-based? Okay, so there's a couple, right? So here, what I wanted to do here, and I know some of it, so Margot's, you talked about this a little bit before, text message to facilitate interaction with a skilled provider in the, okay, high-risk time, early postpartum labor and delivery. Odette, will you say a little bit about yours? Yeah. But can I say where you're recruiting from? So the interesting thing about Odette's work is that she's partnering with a blood bank to intervene with folks who are donating blood and coming back on a regular basis, because there are people who, regularly every 6 months, 3 to 6 months, donate blood, and in engaging with them, using their data to try, their biomedical data to try and understand their risk for hyperlipidemia and other cardiovascular outcomes, and then intervene with them once they've been identified. So it's an interesting partnership because you immediately get to a large group of people very, very quickly by doing that. And then, Jacinda, you had your hand up, right?
Yeah, I have 2 trials. One is a web-based intervention for postpartum prevention diabetes, and the other one is an app for postpartum prevention for dementia, where you have lots of factors.
Yeah. So all of those, you know, in all of these, you're looking at some of these things like evidence of efficacy for positive behavior change, evidence of efficacy for an improved biomedical outcome. We are starting to see that there are a number of trials and publications that show up here. You know, building more evidence in the field is definitely worthwhile. Building more evidence about something that hasn't yet been studied is also worthwhile. We've seen a lot of this is in the area of things like smoking cessation, physical activity, nutrition, mental health, for example. We're not seeing, we're definitely not seeing as much in the maternal and child health necessarily, right, as of yet. We're also not seeing things as frequently with elderly populations. We're starting to see that now. But as you can see, you know, basically the kind of take-home message is that as you move along the columns here, the evidence is thinner on all of these types of things. So sustained effects, we have a big problem with decay in interventions. So I'm going to talk about one, you know, the approaches that you might consider if you want to look at preventing intervention decay. Yeah, Donna.
In the sensors and trackers, are you counting accelerometers?
No, I'm not. If you count accelerometers, right, this would be more full, right? I'm thinking more of the digital sensors that are more emergent, like a Fitbit, those kinds of things, right? But you're absolutely right. Accelerometers, if you were to include that, would fill this in. Yeah. Yeah. Yeah, you're absolutely right. And then the red is where we've actually had some negative outcomes. So this one, Plant talked about an app that is supposed to give you feedback on your blood pressure, and it wasn't really well it wasn't really well validated, and so it was misreading and underreading blood pressure. So people then would stop taking their meds because they thought they were controlled when they weren't. So those are some examples of negative. And then artificial intelligence and VR should probably really be 2 columns, but it's also, you know, emerging great, interesting things, but we don't have a lot of evidence there. So the whole point here is, you know, there's a lot of room for work, especially in the kinds of things that Donna was talking about, in demonstrating efficacy for those kinds of sensors and trackers. Lots of room for work in virtual reality, artificial intelligence, in terms of demonstrating efficacy on this part. Now down here, where we seem to be missing data across the board, replication. Now this is not unique to mHealth. We seem to have a problem in science in replicating our work in general, but it's certainly true in mHealth too. Scale. So when you're thinking about your, you know, things that we need to be doing, taking them to scale is an important priority for the field. And then understanding factors that influence scale. Also, do I have engagement here? Yeah. Oh yeah, engagement metrics, what is it? And these are kind of thin. We only have a few papers in here, not as much as, you know, really how many we have in these other cells. So we have a lot of work to do in engagement, what it takes to get people to open up that app more than once. What it gets to, we have a need for much more work in decay, intervention decay. How could you use mobile and digital tools for boosters, for example, or to supplement or enhance interventions? People aren't doing that as much, or we haven't seen as much of that. So I wanted to bring this up so that people could think about, well, do I have room, or is there an opportunity for me to ask these questions around replication, around avoiding intervention decay, around using technology for boosters or supplemental work or enhanced work? Now, it goes back to that problem of, okay, but will the funders support that? And this is, this is a question that I think, an early investigator is going to have to struggle with. Do I go to a foundation because they're more interested in some of these questions rather than a study section for NIH, who's often very incremental? They'll add one more to this already crowded field up here, looking for things that impact social norms, even though we already know, I'm not going to say we know everything we need to know, but we know a lot more relative to other things. Yeah.
I'll make a generalization that I think it applies here too, and that is the funding for validation of public research seems to generally be inadequate. That certainly could explain why there's not that enough digital health in terms of evaluation. The question is, do you know of any examples of mHealth or health solutions that prior to the market, the scientific consensus was they were adequately validated?
I don't know of any. I think that that's another problem of this disconnect between us and industry, because they're asking different questions. They're, will people use it? Will they engage with it? That's for them. That means it works. But we do have that disconnect. So on our end, on the academic side, we spend a lot of time trying to understand, does it actually work? But then we put it on a shelf and we don't disseminate it, we don't replicate it, then it's on a shelf, and then pretty quickly in mHealth, it's obsolete. And then on the industry side, they get it out there quickly, but we don't really have any idea of whether or not it works. Donna?
Well, I wonder, to me, it just seems like a whole bottle of water. Make a thing and put it on a shelf. The speed the technology changes, we're never going to make a thing. Make a thing and we have to develop a thing. No, just have to sort of choose a horse and bet on it.
Yeah.
And I can tell what that just because and then the funding model also has to be.
Yeah, I think that question about choose a horse and bet on it, it helps me think about, we have some basic science questions that we could understand. And I think there's something there to say, if we had an ongoing effort that was like an ethnography of technology use, we could understand better behaviors about what people engage in. I mean, I have my own little laboratory because I have a 19-year-old and a 16-year-old at home, and their friends are constantly over. And, I'm not a good PTA parent, but when I'm able to participate, I can see other young people too. And so thankfully I had that, because then I never would have thought of using Snapchat before. And now we're using Snapchat for several of our efforts. And so it's interesting to me that having some sort of ongoing assessment about what people are using, in what contexts, at what time, and how, can help us then apply that to a number of different settings. So you could say, maybe it doesn't matter. Maybe what's more important is the platform and the engagement issues, and once you can nail those down, you could apply them to a number of different scenarios. So I think there's something in there that could help us. So I want to go into more depth on each of these, but Donna talked about this specifically, utilizing our theoretical frameworks. We'll hammer home consistently on this. If you are applying to NIH or NSF, they care a lot about this, and you won't get anywhere if you don't have a theoretical framework. And then paying attention to design. So really, this is a key element. I'm not certain that the design piece is well appreciated by reviewers. I think they understand that we have to have something that is usable and engaging, but I don't know that they really appreciate the time and resource that's required to do this well. So everything, you know, when Donna was talking this morning, I was realizing, wow, you know, all of that work means that you're putting so much effort into the intervention up front. The payoff you get is that once it's running, you perhaps don't have as much effort to deliver the intervention. But that upfront time does mean that you're not doing an R21, you really are doing an R01 or at best an R34. A what? Yeah. So I want to introduce this idea. I know many of you have seen this before, but here's where I'm thinking, you know, if you're going to have a better integration of understanding who your users are and what they want and what they use, that kind of ethnography type of situation, you want to understand access and you want to understand engagement. And currently, where we often start in our behavioral interventions in particular is somewhere here. You know, this is kind of a number of constructs that consistently are effective in changing behaviors in real world interventions. Donna mentioned, sorry, Donna, self-determination theory. You could put that in here as well. This also suffers from this, you know, non-recursive nature, right? So it's oversimplified. But we start here, and we don't think about what's unique to the mobile and digital environment is you've got to figure out what people are using. So you can't do I'm going to present this. I'm going to present my intervention for tweens on Facebook, because that's what I use. I don't really use Facebook. I lurk. But that's what people like me use. And so it must be something that's easy for them to use. I don't care that they don't really use it, right? So that's a bad choice. So you have to spend time looking at access, and then you have to figure out what will engage and keep their attention. So I'm going to talk about access first. So this idea of access, when we talk about N of 1 trials, have people tried these N of 1 studies? Will you give us a quick, what it is? What's an N of 1?
So you are studying one person watching the trajectory of one person,
Mm-hmm. Yeah. So you're doing the entire study within one individual, and then you repeat it with another individual and a third individual, and you can iterate continuously. It's very helpful in mobile and digital health because you can get that rapid assessment. You can do it with wireframes. So like Donna had that picture of the game, for example. What do you like about this? What do you not like? Tell me, what would you do next here? Instead of waiting for them to do the whole thing and then say, what did you like? You know, and you can do it in real time. So imagine like I always like to think of the analogy of going to the ophthalmologist, right? You sit behind this little thing and they say, which is better for you, A or B, B or C, A or C, C or D. And that way, you know, you can kind of hone in on what's the precise thing for that person. Now, it depends what you're trying to do, but you may ultimately have something that's highly tailored if you have a very algorithm-driven kind of intervention. So in this way, you can do a lot of great design and formative work by having this approach. Because you, again, if it's just you, you're not going to be able to know what your audience wants. This is a way to get in front of your audience and really get them to tell you what they like and what would motivate them. Margot?
How do you choose your N1? That person is very specific.
Right.
When you're testing it, you tell what you're doing N1.
Yeah. So I would encourage you to think about who your ultimate audience is to drive that question, but it's similar to how you would choose participants for in-depth interviews or focus group discussions. You want a diversity of people, but you don't want to deviate from the, like if you're trying to work with pregnant Guatemalan women, you're not going to do N of 1 with, you know, women in the US, for example, or women who are, you know, past reproductive age. So or pre, right? So you want to figure out who is your audience, and then you're not going to get a representative sample, but you want to try and be purposively selective to include people that will reflect the experiences of people in your ultimate audience. So we're doing a series of N of 1 studies now for a trial that we're developing across multiple systems, and we're doing work at the VA, at Denver Health, and UC Health. So we want to get 20 people from each of those systems who have the cardiovascular conditions that we're looking at, and get their input. Different gender, different age, different race, ethnicity, and different income level. So within 20, you know, we're going to try and do a matrix and hit all of those. Are there other questions about N of 1? And then it can facilitate engagement, but in that process, you can try and understand, you can ask questions. What do you use most often? Do you have a cell phone? Do you have a smartphone? What's your favorite app? Why did you choose that app? What made you download it? What difficulties do you have in using it? Will you open it and show me how you go through it? Those are approaches as well. You can also, this is that when Donna talked about that agile development process, you can use that framework with N of 1 where you're doing, you know, your first 5 to get that first process, and then you do your second 5 after you've made some changes, and then you do your third 5 after you make the next set of changes. So the N of 1 can help you with that. At the same time, you can ask these questions like, should I be using this on Twitter? Should I be using this on text message? If I use it on text message, will you pay attention to the message? And we got, when we've done work with young people, for example, they said, I won't pay attention to the message if it's a telephone number I don't recognize, and especially if it's one of those 5-digit numbers where it's three numbers and then a dash and 2 numbers. I don't know if you get those, but those are kind of bulk text messages that come out usually for advertising. So people will tell you, no, I won't pay attention to it. So maybe I do pay attention to text messages and I get 300 a day. I don't, my teenagers do. But you have to figure out, well, what will make you pay attention to my text message? And we've been hearing about things like branding. This is a text from Denver Health. This is a text from your physician, you know, maybe even your physician's name. And then Donna mentioned this, machine learning. You know, there's been a lot of great work recently in machine learning using like scraping Twitter feeds, for example, to understand emergent patterns for flu. And you can get a lot of information up front about that, about where and how people are using technologies and what they're doing with those technologies. You'd be surprised. People do post things about what they've eaten or what they're feeling like, or you know, what they're physically feeling like, or what their mental health status is. And you can also do, you know, you can do traditional methods, but you can use technology to do those. We've been using basically online discussion boards as a forum for getting asynchronous focus group discussions done. This is a little bit hard because you have to really poke people and help them understand how you want them to post the information that you're seeking. So that's a little bit more guided. Now, in the concurrent session right now, Blaine is talking about user-centered design, and I'll just put a plug in for the importance of it, right? I think you can't emphasize enough, and given what Donna presented this morning, really the rich and detailed amount of work that's necessary to get something that people will use. And so here, this is one model. I'm not saying it's the only model, but it's a model that you might consider called the user interface, the People at the Center for Mobile Application Design, PACMAD. It's a model that looks at the types of things that, that we consider important to facilitate successful use of your tool. At the end of the day, if you investigate your tool and you haven't done this kind of work up front, and you know, and you find out that your solution has failed, you don't really know, is it failed because people can't get through it? They experience errors, they just don't like how it looks, or they can't figure out what it is that you want that is wanted of them in engaging with it. So what PACMAD does is it provides a framework. So it's kind of like a theoretical model for the user interface piece. So it provides a framework for you to ask the questions that are critical, then to be confident to say, I've got a tool that people can easily get through, that has either no errors or minimal errors. It doesn't freeze or block or, you know, bump you out. People seem to like it, and they can quickly, once they open it, they can quickly get to the task and complete the task that you want of them. So this is the framework, and using that as a framework to assess when you're developing your tool, whether or not those things are in place, can help you then in your beta test to be able to say, my tool now works or functions the way I want, it's ready for trial. So I would say don't go to trial unless you've done this work. I would also say don't do this work until you've done the N of 1 or some sort of formative work that really informs what people want to use, how they want to communicate with you, or how they want to get information. So that speaks to this issue of engagement. We can't, I think 250,000 apps out there devoted to health that are open to median of one time illustrate to me that we haven't done our work in this area. That we have really, what people are really wanting to do is, I've got a great idea. I had a guy come to me a year and a half ago. He said, I've got an idea. I'm a computer scientist. I'm privileged. I've got a lot of resources from my startup. I want to give back. So I'm going to create widgets for kids that they can put in their Crocs that will monitor their steps. And I said, that's great. Who have you tested this with, the idea? And he said, oh no, I'm done with it. I want to just put it out there. How do I do that? So he hadn't done any of this work before. He just built it, right? It's that field of dreams concept, build it and they will come. It doesn't really work in our field. Okay, so then this next piece. So if anyone is really interested in this idea of dose response. So this is an area that really is ripe for us in mobile and digital health. So if you think about it, what advantages could we achieve in the field by asking questions about dose and response? And what do you understand by even that terminology, dose response? Susan.
How much of something do you need to get the desired outcome?
Yeah.
How much interaction?
Yeah. How much do you need, and how much of what do you need? So you need to both, in order to get the outcome that you're interested in. Yeah. Yeah. So Donna mentioned this, for example, like, why would you keep sending me messages about physical activity if I'm already doing the physical activity? And then how many of those messages did I need to get before I started doing the thing, before I started doing the physical activity? So that's what we're talking about here. So we're not doing dose response. That's kind of part of that black box thing where we have evidence that people exposed to interventions using mobile solutions can get an outcome. They can stop smoking, they can reduce their substance use, they can improve their mental health, but we don't know what's in the black box. How much do they need? what do they need, how often do they need it, and what time of day, for example. So those are critical questions. And is there a dose response with engagement with content and behavioral outcomes, or biomedical outcomes? Both. Those are, for folks that are thinking about that, that's a great option. Now I want to suggest that SMART trials are a good way to kind of ask and answer some of these questions. Is anybody, I know some folks are familiar with SMART trials. Have other people heard about this idea? It's called sequential multiple assignment to randomized trial. And so I'm going to give you some examples. So the idea is that you can sequence decisions. So if the first element does or doesn't work, you can randomize people to a different element. So I think it might be easier to give you some concrete examples. Oops, what did I do? Okay, here we go. Okay, so here, here's the R in this visual represents randomization. So here you've got a trial where you're randomizing them to two groups. Okay, this is a trial of pregnant women who abuse drugs, okay? Traditional and then reduced. I'm not sure what the RBT stands for, but this is the intervention. Did the woman comply with treatment in the traditional arm? If yes, so she's done the thing that you want her to do, then you randomize her to, okay, do we need less of it? Or do we keep the same? And so that's kind of a way to answer a dose response question. How much is it? Rather than doing it post hoc, which you could also do, you can do it during a trial if you do it this way. If she didn't comply with the treatment, then you can do the same thing, keep the same treatment, or enhance it, like supplement it, right? But these randomization arms can be built in up front so that you're not having to wait until the very end of your trial to then start unpacking. What was my dose? What was my response? Because even then, if you wait till the very end, you might have some difficulty in understanding which element was the most important and how much of it did they need. Are there questions about this? I can show another example. This is for adaptive treatment for growth suppression in children with ADHD. So you've got randomization to either high intensity or low intensity medication, low intensity plus medication. And here's an answer. Did the child's BMI decrease? No. So you keep the same intervention. Did it decrease? Yes. Okay, so do we do monitoring? Do we just do medication with drug holidays on non-school days? Or do we change it altogether to caloric supplementation, for example? Does that make sense? So here, we might do something like, if you've got a text message intervention, did the text messages help this person increase their exercise? Yes. Okay, then let's keep the same text messages, or let's reduce the number, or let's just try a simple generic text message and end it, for example. So you can randomly assign them so that you can still keep the benefit of randomization. So those SMART trials are starting to be used. This is one of those things where I'm just not sure how much NIH reviewers are fond of them. Do you have a sense? Oh, sorry. Yeah. Yeah. And it also helps you to facilitate tailoring. So if you want to create an intervention where you've got a high degree of tailoring, say those N of 1 studies have helped you understand that for some folks, they like gaming features. And so you're going to include gaming features. If it's a select your own adventure type of thing, right? for other folks, we found this in a formative work for a smoking cessation tool that we're helping evaluate. And we found, interestingly enough, this gendered kind of binary where men really liked the gaming things. They like getting points, they like getting badges, they like getting the attaboys. Women really like the relational things. I like to talk to my coach, I like to post and get peer support. So it was not clear that they could design a one-size-fits-all. So they were able to tailor, and you could do that. Okay, in the last few minutes that I want to talk about, again, this idea of the theoretical considerations, and that goes back to access, this idea that we're not really reaching the highly marginalized groups. And some of you all alluded to the reasons for this. The commercial industry, they don't particularly care about people who may not have the money or the resources to buy their widget. So they're not necessarily designing for them in mind, but we care a lot about them, and because they're the folks that face disparities. So here, this is an issue of access and thinking about, okay, well, where are you working? If you're working in a lower or middle income country, doing something with a Fitbit or a sensor may be premature. You know, we may be 20 years out on that. But there may be things that they're doing that leapfrog us, right? They're doing mobile banking, and it's not taken off in this country as well. So really that access question is critical. And then finally, I wanted to touch on this idea of replication and scale. So I come back to this idea that mobile health interventions may never have the level of effects that in-person intensive interventions might have. So if you have 10 people and you've got an intensive intervention and it might have an effect size of 0.3, for example, great for behavioral scientists. But we're not going to see that in mobile health as much. So we're always going to have small effects. So the only way we're going to really have impact is to reach a large number of people. So we need to be thinking about dissemination and replication at the outset so that we can improve our impact. So it means that we need to understand more. We need to, first of all, we need to replicate. So doing replication studies is important. Now this is also hard to fund because NIH likes things that are innovative. So if you're replicating and you want to replicate, I think replicating with diverse populations is a way to go, different audiences. But then that means that you need to really think about that in the beginning so that you can minimize the cost for adapting your tools. And then asking the questions about, this is like a re-aim question, if you're familiar with that. Russ Glasgow is one of our panelists this afternoon, is one of the folks who designed this idea that when we're thinking about scale, you have to be asking questions about who will be adopting your tool or your widget. Are you going to sell it through the App Store? Or are you going to get an institution to license it and use it? We're working on one with breastfeeding support for Latina mothers. And we're talking about, okay, does UC Health want to support this as a way to help moms as they're leaving the hospital get a useful tool, and will they license that? But what would it take for the nurses to adopt it and use it and help moms to use it? We have to ask that question. That's a research question in and of itself. Once they've adopted it, what will it take for the system to implement it and support it over time? Oftentimes those are financial questions. Will the system see an economic benefit? Does it mean that fewer people are coming back in with complications after using this tool? Those are the types of questions. And we are not asking yet or answering economic analyses, cost effectiveness and return on investment. So some of our teams are missing the economists too. So I would say that we need to include them. So these are our summaries. Consider access, consider engagement, think about dose response, smart trials, PACMAD, N of 1, machine learning, and cost effectiveness. Those are all things that I think you should keep in mind as you're designing your trials. Margot, maybe one question?